All right. So, welcome everyone to our second focus group session for the Oregon Prescription Drug Affordability Board. And again, my name is Linda Wyatt. I'm a healthcare senior manager here with Myers and Stauffer. We are a national accounting and compliance firm supporting government-sponsored healthcare programs. And I am joined again today by my colleague, Bobby Courtney, who's a principal here at Myers and Stauffer, and he is also helping to facilitate today's discussions. And so as a reminder, we are recording these sessions to ensure that we capture the feedback correctly. If you wish to speak and are uncomfortable with having a specific comment recorded, please let us know and we can temporarily stop the recording. A few other introductions. Joining us from the board is Shelley Bailey, the board chair. And Shelley, I was trying to scan the list. I believe that you are the only board member in attendance today. Let me know if I missed anybody.
I believe that's accurate. So welcome.
Okay, thanks. Very good. And then from the Affordability Board staff, we have Ralph McGrish, who is the executive director, also joining us today. And then finally, I would like to introduce Jane Horvath of Horvath Health Policy, who is also supporting the board with their work. So let me just run through some logistics again, very much the same as last time, but I will just put them out there again in case we have any new attendees. First off, we do appreciate your willingness to share your perspective on this important topic. And in many cases, you have joined us for both sessions, and we very much appreciate that. So for this second meeting, we're going to do a quick refresher of the UPL slides that were presented at the first meeting. Again, just to kind of remind people what we talked about at a high level last time, or to bring people up to date if they were not able to attend the first meeting. And then after the slides, we will get into our constituent group discussions and continue what we started talking about in meeting one. And so as a reminder, our goal with these sessions is to get your perspectives on the use of upper payment limits, or UPLs, to improve drug affordability and gather any recommendations you have on improving drug affordability for Oregonians. And these sessions will inform the board's work on developing a plan for establishing UPLs as required under Senate Bill 192. And so at this time, the board is not setting a UPL, but they are gathering information to include in a report to the legislature regarding potential approaches to a UPL. We will capture any questions or concerns from the group as we're preparing our reports for the board. And again, as we did last time, when we get to that point in the session, we'll ask you to introduce yourselves so that we can accurately capture your feedback in our notes. We do ask that you mute yourself if you're not speaking. And since we have a large group again today, I would ask you to use the raise hands function on Zoom. That way we can make sure we don't miss anybody who wants to speak or make a comment.
Hey, Linda.
And so during our presentations and discussions, we are not able to answer specific questions related to methodology or affordability evaluations, but we do have a mechanism for you to submit those directly to the PDAB for consideration. And we'll have that on the last slide, and I will pop that into the chat as well. So that said, we will jump right in. As a reminder, again, for the purposes of level setting, since this presentation is given to multiple constituent groups with different roles in healthcare and different understandings of the supply chain, we did put this slide together to illustrate the basic process for retail and health system or physician administered drugs, and their system of payments.
Sorry, Linda, sorry, but we're not seeing the slides.
Oh no!
Sorry,
I'm so sorry. Thank you.
I thought maybe the introduction wasn't necessary. The slides for the introduction maybe weren't intended to be up, but
no. Oh, thank you.
There we go. All good.
All right. Sorry about that. Thanks for stopping me. So
yep, no worries.
Yeah. All right. So this slide again is one that should look familiar to you. It is the one we presented last time with a basic process for retail and health system administered drugs. Anyway, it's attempting to describe at a basic level the associated system of payments, rebates, and product flow within the supply chain. And so in this diagram, we're looking at a situation in which the UPL could potentially be implemented at the top of the supply chain flow. We also looked at this slide last time, and this offers a little different way of looking at a UPL model. So we offer this as a conceptual representation of the model, and this is adapted from work that was conducted by Jane. And specifically, this is intended to illustrate the progression of the UPL through various parts of the pharmaceutical supply chain. And as a reminder, on this one, the concept sits between the manufacturer and the wholesaler. And so currently the supply chain is oriented primarily around a wholesale acquisition cost, WAC, AWP, MAC, FUL, or similar metric. In the 2022 report to the legislature, the board describes their concept for a UPL in Oregon, including that it establishes a maximum amount that can be paid for a prescription drug in a concept that's likened to a federal upper limits or NADAC or MAC prices as they are currently established and used in prescription drug reimbursement policy today. And so the proposed model would be for the UPL to replace these metrics for the supply chain transactions along this kind of continuum for a prescription drug product that's dispensed or administered in a state, and in this case, of course, specifically Oregon, when a UPL exists for a particular drug. And so as noted in the diagram, the UPL is independent of dispensing or administration fees. And so as a reminder, we also looked a little bit last time we looked at this slide, which really looks at recent industry events that might serve as a guide to how a UPL could work in the marketplace. And we do want to come back to this concept in the session today, time permitting, of course. And notably, for a refresher, there was a recent change to the federal Medicaid drug rebate program rules. And it had an impact on the rebate rates that would be paid by manufacturers, in some cases significantly. And in response, manufacturers for certain highly rebated drugs in the Medicaid space implemented reductions in the WAC for these drugs. So with all of that as background, we will move now into the group discussion. And as a reminder, just remain on mute. Do give us your name and organization when you're making comments, and use the raise hand feature in Zoom so we can make sure we can identify anybody who wants to speak. I mentioned written feedback could be provided as related, or written feedback can be provided to us directly through the Oregon PDAB mailbox around the group discussions or survey concept. If you could get that back to us by next week, we would appreciate it. You can also participate in the board public comment process through the mechanism that's on the screen. And the link is there. I will, as I said, pop that into the chat as well. We did send out a survey in advance. If you have not submitted your survey yet, if you haven't submitted it yet, we did leave that open, and we would ask that you get it back to us by the end of day tomorrow. Okay, so with that said, I will turn it over to Bobby to kick off the conversations. Move us forward. Bobby, did we have a question?
Yeah, before we get started, Melissa, if you've got a question or a comment you want to add before we get started.
Well, I just want to add a comment when we get started. So
okay, well, we're ready to kind of jump into some of the discussion. So did you have was it more logistics, or was it relative to a specific kind of topic around
it's
the
relative? Yeah, it's relative to a specific topic around the UPL.
Okay.
So
well, go ahead.
I just wanted to make a comment about sort of the way that the state has set up payments for hospitals and for specifically for infusions, and how that really contributes to wildly different reimbursement for drugs. So we have two different types of hospitals in the state of Oregon. We have DRG hospitals who are paid a set contracted rate for infusions. And then we have AB hospitals that are paid a percent of whatever they want to charge. And so I think, you know, that disparity in hospital reimbursement should really be looked at by the PDAB, you know, the board, as FQHCs and as, you know, smaller independent pharmacies. We are already getting reimbursed less than we are paying for our drugs very frequently. In fact, if people don't have access to 340B, they are closing their doors. We are seeing pharmacies across the state shut their doors, and we're concerned that if primary care drugs, drugs coming through pharmacies that we're dispensing every day are then we're getting even lower reimbursement, that's going to continue that exponential closure of hospitals, especially, of pharmacies, especially in rural areas. So I would love the board to really take a look at infusion payment at hospitals and take that into account when thinking about upper payment limits. Thank you.
Thank you, Melissa. We appreciate that comment, and I think that, you know, we've probably got some questions throughout the session here that we might be able to kind of dig into that a little bit more as well. I'm curious, just in case I missed it, what organization were you with, Melissa?
I'm the Director of Pharmacy Services at Mosaic Community Health.
Great, thank you so much. Okay. Well, let's go ahead and jump in, you know, to the more structured questions. You know, we've got a great group here today. It looks like it's pretty sizable, so we look forward to some lively discussion. Wanted to just start out this kind of portion of the session by, you know, asking, because we do have, you know, some similar attendees and some newer attendees from our last call, whether there are any sort of follow-up thoughts relative to the last discussion that you know, attendees had that they wanted to share. You know, if you'll recall, we spent the majority of our last call sort of talking about affordability generally and sort of what it means to your organization specifically, really to level set around the concept for purposes of the conversation. So we discussed really kind of what affordability means in terms of, you know, the you know, budgets, patients, both positive and negative on your organizations, just to kind of level set. But like I said, we've got a number of new attendees on the call, and you all have had some time now from our last discussion to probably think through this topic a little bit more. Just before we dig into the specific questions, wanted to see if anyone had kind of follow-up or additional thoughts on our conversation from last week. And if not, we can go ahead and pick up where we left off, discussing really sort of potential UPL impacts. We had started this conversation and got maybe a couple questions in, so I wanted to circle back there. So we'll talk about UPL impacts and then move on to a discussion of the methodology, specifically sort of what should be considered or not considered in actually calculating the UPL. Talk about kind of the desired state or you know, envision desired outcomes for a UPL program, and then talk similar to Melissa's comment about any other recommendations you might have relative to the UPL program specifically, or the board's ability to do its work in general, or you know, options for the board to kind of tackle in general. You know, as we've stated before, the information here is, you know, these are really designed to be listening sessions. Want to solicit as much input and feedback as you have. We'll sort of incorporate all of that into a final document and share with the board that they'll leverage to fulfill their statutory obligation to the legislature in terms of providing a report back on this topic. So again, just kind of doing some level setting. So first question, you know, and Linda, if you want to go back to the slide that you had on the WAC changes.
Oh, sure.
I'd appreciate it. Thank you. So sort of thinking back to this slide that Linda had in terms of the recent WAC changes and some of the impacts, I wanted to ask this group specifically, were there noticeable impacts to your organizations as a result of this? If so, did you have to make any operational changes, either in terms of purchasing or administrative decisions? But given that, that this is arguably analogous to, setting a UPL, we wanted to sort of see, how your organizations responded to this particular event, if you're able to share. Marty, go ahead.
Thanks. Marty Carty with the Oregon Primary Care Association. I don't have a specific example to offer to answer your question, Bobby, but I think I would caution the use of analogous or an analogy that closely ties the changes at the federal level to a UPL in a state. And I say that because those federal changes, as you know, have a national impact. They force manufacturers to make those adjustments in every state. A UPL in a state like Oregon, where the market share in the pharmaceutical industry is small as compared to many other states' GDPs, I think I just would really caution us to draw too close a parallel thinking that a state UPL would have a similar impact as a national policy does.
It's fair.
Yeah, and I think, Marty, when we think about it, the analogy, it's not, and you're right. Your point is spot on about it being a national impact and market share and quite impactful. I think our thinking was it's analogous from the point of view that it changed reimbursement in a way that we don't often see, right? It's not very often that we see a WAC go down, right? How often except when there's generic competition, but how often do you see a WAC go down and in some cases quite sizably like this? I think was really more the thought that we had around it being perhaps in an analogous situation from an impact on revenue or needing to make operational changes.
And in terms of those operational changes too, Linda, I mean, if things like, prescribing or dispensing habits, based on that reduction, things like that, I think that's what we were trying to tease out a little bit, Marty. I mean, your point's well taken. Just trying to understand if that prompted any specific, or different actions.
I'll have to let my health center colleagues answer that question.
I think it's Michelle.
Yeah, hi, I'm Michelle Coder, Multnomah County Community Health Center. Are you referring to the lifting of the AMP cap?
Correct.
So we haven't realized the impact of that because it takes 2 quarters to catch up with the 340B price. So we're anticipating to get hit with that in July. I can tell you from my perspective, it will likely make us change which drugs we dispense. It may make us change to drugs that are no longer preferred for a particular disease state. So, for example, we currently cover Lantus for uninsured clients. That could result in us going back to NPH or something like that, right? So I think there's going to be clinical impacts of that as well as financial impacts.
Thank you for that, Michelle. Do others have similar experiences or different experiences they'd like to share? Jennifer, go ahead.
Hi, good morning. I'm Jennifer McElravy. I'm the Director of Pharmacy at Neighborhood Health Center. And just to echo what Michelle said, I think we're all of us who work in the FQHC space have 2 concerns. Number one concern, like what Michelle mentioned about the lifting of the AMP cap and how that's going to impact our 340B prices increasing. We serve at our in-house pharmacy a significant amount of uninsured patients on a sliding fee scale. About 38% of all of our prescriptions that we dispense are for uninsured folks. And I'm really concerned about how, we've been buying these penny insulins and we've been dispensing them on this sliding fee scale, and how is this going to impact our patients? So the other thing I'm really concerned about with the PDAB is, number one, well, first of all, like I said, our 340B prices are increasing, and then we've got this potential impact on the upper limit. And then I'm concerned about how that's going to impact our savings. So it feels to me like this is going to significantly potentially shrink our savings, which, this is a big deal for us as a health center. Our 340B savings are every penny goes back to serve the patients that need it the most. I mean, we're using our savings to serve our uninsured patients. So this is, this is significant. And I said in my survey, I said, is there any way to potentially carve out FQHCs from this upper payment limit program?
Thank you, Jennifer. Appreciate that comment. Others, similar experience or different experience, either in terms of, operationally, how you anticipate responding to, to the decrease, or, concerns about, Jennifer had mentioned, potential, carving out of, the 340B covered entities. Part of what we want to hear here are, solutions, potential recommendations or solutions to mitigate some of those unintended consequences or potential negative impacts.
This is Marcus Cox. I'm the pharmacy director for Klamath Health Partnership in Klamath County, Oregon. The increase in the WAC cost, of course, is coming right in the fourth quarter. So July, we're expecting that. I'm concerned about just, our patients on our sliding fee scale program. We pass on the cost of the medication to them. So that's going to be significant to us, very much. Already with the reduction in reimbursement that we've been receiving for the last few months, that significantly hurt us. Probably about 70 to 20% of our revenue has been reduced to us because of that. And that's a significant hit to our, relatively small FQHC. That financial hit to us is going to be incredibly significant. And then come July, when our prices increase, that savings is going to reduce, and that's going to be another effect to us too. So as small health centers that are really trying to provide a savings to our patients, these things become incredibly important to us. So thank you.
No, thank you, Marcus. Appreciate the feedback.
I do want to mention for the record, Marcus, thank you for sharing this very specific example of how it'll impact you. For the record, Linda and Bobby, I would like to make sure that we edit the recording to remove the pricing reference, just because prices are proprietary, and I want to make sure everyone who's been so willing to communicate here with us today that we protect their pricing contracts. So I just would like, for the record, to make sure to put in that request.
Will do, Shelley. Thank you. Any other comments on the WAC impact, the WAC decrease impact, and responses to that before we move on? Okay. Our next question is really around, Marty, go ahead.
I was going to offer, if it's helpful, and I don't want to speak on behalf of our health center members here today, but after they realize the impact in July, if you are interested and the timing makes sense, is there something we can bring back to you to better, in a more detail, answer this question? And again, I have to rely on health center pharmacy programs to provide that because we don't have it here at the PCA. But if you want that information, in July, we'd be happy to try to pull that together for you.
Yeah, I mean, I think that anything that you can share that can help us understand and articulate the issues and the experience of your members around this topic, we'd be more than welcome to review. I mean, and consider sort of how we incorporate that into our feedback to the board, regardless of the timing for our work. I know it's something that the board would likely be interested in. So yeah, I would say that if that's something that you can pull together and share, we'd certainly be interested.
Thank you.
Next question, in terms of some of the survey responses, several respondents indicated that, and we've talked about here in terms of affordability, co-pays and whatnot, but the idea of challenges for patient access to medication. So, are there things in addition to co-pay, your ability to purchase, things like that, challenges that you envision the UPL might create in terms of access? Melissa, go ahead.
Yeah, I think we're already expecting some major changes to Medicare this upcoming year. We know that donut hole is going away and that we are expecting major changes to Medicare formularies. I've already heard from our CCO that they will be significantly tightening up their formulary, which could have pretty significant changes on what we're able to fill for patients and the affordability of those medications. So I think that's something that we're anticipating for coming out this next year.
Thank you for that, Melissa. Similarly, I mean, would you, anticipate changes in benefit design, kind of strategies, things like that, that could also, kind of trickle in and impact patient access?
Yeah, definitely. And I think, all of us as FQHCs have already been hit over the last, 4 years since the middle of 2020 by manufacturer restrictions for contract pharmacies. So many of us are losing millions of dollars to our health centers already. And so it just feels like, PBMs are taking more and more, the manufacturers are taking more and more. We're filling more and more prescriptions for the community and for our patients, and yet our revenue continues to drop, and we have to start to really look at our services. What can we not, give anymore to our patients? What are we not able to provide because we can't pay for it? And so to me, this is a little bit disheartening. I think the fear for health centers that we are potentially eroding our safety net even further. And I think for larger health centers, they may be able to get by, but for smaller health centers that have 1 or 2 clinics, this could be really threatening to them. And so I just hope that the board understands that.
And I'm curious, just to kind of pick apart a little bit, Melissa, your comment, because and apologies, were you able to attend the first call? Because I don't want to ask you the same question if you'd already shared this.
I wasn't, no.
And I'm curious, and I had asked this of a couple of folks during the last call, when you talk about the services that for your organization that you're concerned you wouldn't be able to provide. Are there specific services that come to mind that are those high priority, the ones that have been sort of supplemented through these additional revenues that come to mind for you that you think would be most at risk?
Yeah, so our entire clinical pharmacy team, which does all of our Hep C treatment, diabetes management, hypertension management for the organization, is all paid for by 340B dollars and through our pharmacies. We have a mobile clinic and a street medicine program where we're actually going out to houseless encampments to provide free medication that would be at risk. I mean, there are a number of services that we offer that are non-billable services. You know, a lot of nutritionists aren't covered by certain commercial insurances, et cetera. So those are the things that we really fear that we won't be able to continue.
Thank you for that. I think that's consistent with some of the other examples that we heard during our prior call. So I appreciate you, providing that to sort of, get a full kind of picture, a more clearer picture. Similarly, Marty, go ahead.
Just, and I know probably said this last time, just a brief reminder. I want to make sure you hear this and record it loud and clear. The 340B program was designed by Congress to meet the needs of the safety net. And so I think it's frustrating on one hand where manufacturers and PBMs continue to erode it. I get it. They're in business to be in business for themselves. But when states are looking at also eroding the 340B program, and Ralph, I'm not picking on you or the team individually here, but it feels really frustrating when we look at it and we say, Congress created this. The intent of the program was to fund the safety net with non-taxpayer dollars. And now we're looking at taking those resources away, and we're not looking at ways to supplant it. So I think both of those, if we're going to take resources away, I think the legislature needs to hear loud and clear, you're going to have to find a way to pay for it in a different fashion, because outcomes will suffer. I mean, you lose a whole HIV clinical pharmacy program. What does that do to a community where there is no other program? So I want you to all hear it loud and clear from us on a statewide organizational level that it's not okay to take away resources from a program that this was Congress's intent.
Sure. Marty, thank you for that. And if I can, real quick, Bobby, just jump in and just to make sure that most of your membership folk, if not already aware of this, that in the board implementing Senate Bill 192 and our obligation to deliver this report to the legislature, the defined groups that we were to engage and do an analytic work with were in fact hospitals, pharmacies, carriers and consumers. To that point, and Marty, I'm grateful for the collaboration that we've had in developing and bringing this group together. You know that the board identified 340B providers and safety net clinics as yourself as being a critical piece of this conversation. So we took it upon ourselves to add you to this conversation, knowing the importance of the role that you play in your respective communities, which we all as Oregonians appreciate. So just want to make sure that everyone is aware of that based on the work that you all do, we knew and we know the value of what you do. So thus the importance of adding you into this conversation. Thank you.
And Marty, and others for that matter, do you envision any particular, or can you envision any particular, alternative policy solutions? I think Melissa had mentioned, carving out 340B. Are there other, policy solutions or, considerations that could be made in terms of how the UPL might be set or how a UPL program might be leveraged that would help to mitigate or address, some of that potential loss of revenue?
I think the structural problem, Bobby and Ralph, is that the program exists at the federal level and states, right? Like the program exists at the federal level and we don't have any latitude to change it. There isn't another funding stream that brings this amount of money that's not taxpayer dollars into the safety net. And so we could say things like, Lisa, I think on our last call shared, thinking about, drugs that aren't, let's put a UPL on things that are not 340B eligible. Melissa, her comments today around, infusions and how we pay for things in the hospital environment, I think that makes a lot of sense. But ultimately, the program is a federal program. The program's intent, as I said, is to fund the safety net with non-taxpayer dollars. And I cannot I have racked my brain for months around how we would do it differently. And I can't think of a way. I've asked our national folks as well to think about this, who are way smarter than myself. And nobody's come up with a way. I've talked to the other states, the primary care associations in other states. What are you thinking about this? It seems existential, and they all feel the same way. And nobody has good ideas other than to say, well, we're going to have to go to the legislature and ask them for money to supplant the losses. And Melissa's right. And I'll share it again on this call. We surveyed members, and out of 13 responses, just from the contract pharmacy restrictions, I know they're not analogous, but I want to point this out. 13 health centers reported in 2023, $23 million in losses from manufacturers' contract pharmacy restrictions. Those dollars haven't been supplanted. They haven't come back. And so health centers are figuring out how to do the same thing with less. Adding in a state UPL that impacts a 340B program will only further erode the safety net and put us in a position where outcomes ultimately suffer and patients suffer. So I'm sorry, I don't have a good policy solution to bring to you. I can't echo enough that I think the right answer is that you just carve the 340B covered entity out. You can decide which covered entity types. You can, and I think we would happily think about what transparency in spending in organizations looks like. That feels like our duty would be to say, look, we will happily report how these dollars are spent. We can come up with some categories or some other ways to be more transparent. But I think the reality is that we can't sustain additional pressure on the safety net 340B program, particularly for covered entities who are the FQHC covered entities, who are the only entities that have a federal mandate to reinvest those dollars into patients. Other covered entities, such as hospitals, do not have that federal mandate. So I think they fall in a different bucket for us. Not picking on our hospital friends, but I think that's just the reality of the landscape.
Thank you for that, Marty. I appreciate you making the distinction between the FQHC obligations as compared to the hospitals. Okay, well, I want to be mindful of our time, so I'm gonna jump ahead a bit and talk about. I think we've got a lot of good feedback here in terms of impact, but I'd like to move on to thinking about really kind of implementation. If there were a UPL program or UPL pricing that were implemented, several of the survey respondents indicated that it would be difficult to actually implement that, frankly, due to operational challenges with respect to members or payers in other states, things like that. I'm curious, are there other challenges that folks envision? Are there things that the board should consider, to mitigate those challenges? Just kind of curious your thoughts on sort of implementation specifically. Michelle, go ahead.
Yeah, my recommendation is to do some modeling on what the impact will be to PBMs, because I guarantee you this might reduce costs for payers, but PBMs are not going to be losers in this. They are going to find a way to make themselves whole. And so, if there's a reduction in payment by insurers, I guarantee you that money is going to go into the hands of PBMs.
Michelle, this is Ralph. Is there a modeling exercise that you would propose, or anything even at 70,000 feet that would help inform that conversation on our side?
I think OHA will have that data, or the DCBS will have that data with the new PBM bill moving forward. So you can look at how much rebates they pass on to payers, et cetera. But I guarantee you they're going to make themselves whole in this situation. And they are the primary reason why our drug prices are high in this country.
No, appreciate all of that. And for folks that may not be tracking what Michelle is saying, our other program that I co-manage is the State Drug Price Transparency Program. And beginning this calendar year, DCBS is beginning to collect aggregated information from PBMs on gross rebates collected, the amount retained as profit, the amount retained, or the amount returned rather, to employee sponsors of healthcare, and that kept as profit, or I think I said returned to the enrollee at point of sale. So that is information that we're beginning to collect now, and we have an obligation. We'll have that up on our website by October. But to that point, if there were specific modeling exercises or things that you thought might help inform that, to make the points that you're making, Melissa, we would welcome your input there.
Melissa, go ahead.
Yeah, I just want to echo Michelle. I think that's probably the fear of a lot of us, is that, you know, if we are trying to make drugs more affordable for patients, I highly doubt that this will actually make it down to the patient level at all, because I think the PBMs will figure out a way to keep whatever that savings is. So unless there's some sort of mandate that the board is planning to say to PBMs that you cannot keep this money and it has to be passed on to a patient, they will, I am certain they will figure out how to keep those dollars.
Thank you for that, Melissa. Russell, go ahead.
I think the idea behind this is good intent. I'm with an FQHC as well. But I think the pharmacies getting targeted, and to be able to be the resource for the patients to decrease the drug cost is not where we should be looking. You know, they're creating the distraction over here and we're focusing on the other thing. The PBMs, like everybody else is saying on here, is a big contributing factor to drug pricing. And we are in Washington and Oregon State. And in Washington State last year, we lost 60 pharmacies across the state. Oregon, I think, had 35 or around there, 35 to 40. So the pharmacy is very difficult to really have a good bottom line anymore. And 340B entities, we use we reinvest these dollars continuously so we can be that safety net provider for a lot of patients across both states where they really wouldn't have healthcare because of rural locations and things like that. So I think the target should not be pharmacies. We are doing things with like Melissa said earlier, we're doing a lot of clinical pharmacy, registered dietitian, nursing visits, those things that don't get reimbursed. We wouldn't be able to offer those services anymore. And that is really going to affect outcomes for our patients, as well as accessibility for patients, because clinical pharmacists can see patients on a more regular basis. And we can do things that, like, say, nurses can't do, registered dietitians can't do, and providers don't have the time to do. So we're in there really helping with outcomes and really helping improve patient care across the board. And those services will go away because we're just not reimbursed for them.
Thank you for that, Russell. Briefly, before we move on to, again, trying to manage our time, I don't want to be keeping people all afternoon, but before we move on to the methodology specifically, just want to ask one more time in terms of sort of the operational implementation challenges. If, in fact, just say for sake of discussion that, UPL price was set, are there particular challenges with implementing that? Whether operational or, to your point, Russell, you've got, clinics in other states or maybe payers from other states, things like that. Are there sort of administrative, operational challenges that might be associated with implementing a UPL?
Yeah, I think by being in two different states, that would be pretty burdensome on our pharmacy software to be able to have, you'd have to do programming for different states and different plans, and yeah, it would get difficult. Yeah, I also want to, I'm going to plug something real quick here for Oregon. Please don't follow Washington's crazy idea of not allowing automatic refills for Medicaid patients. Horrible idea that was in place. It's causing a lot of issues with compliance and adherence to medications. So please don't follow suit with them. It was a bad idea and it's only getting worse.
Thank you, Russell. Okay. Any other comments on implementation before we move on? Okay. We talked a little bit, or Ralph had asked the question about sort of modeling and how the board might look at look at a methodology or the impact of a specific methodology. Are there data points that the group feels would be sort of important for evaluation when calculating a UPL, recognizing that there are transparency issues at play and confidentiality issues at play, so there are certain challenges, but are there specific data points that would be critical to consider in setting a UPL methodology? We've had some of the survey respondents mentioned as an example, medical necessity, things like that, really thinking outside the box here.
And Marty, if I can just speak to the note you put in the chat, we are in fact working with the tribes on coordinating a request for a tribal consultation. So appreciate that. Thank you.
In terms of data points, specific information to support decision making, particular analytics that that you would recommend the board perform. Justin, go ahead.
Yeah, this is Justin Ramsey, the pharmacy director for La Clinica, a small FQHC health center in Jackson County, Medford, Oregon. Just wanted to reiterate that any upper payment limit that's applied, in terms of our pharmacies getting third-party reimbursement, any dollar amount that's decreased by a UPL is a dollar out of our reimbursement. So it is direct and negative to all 340B entities. In terms of solutions, reiterating what was said, to exclude FQHCs somehow or apply the upper payment limit to drugs that are not in the 340B program would help. I don't know the feasibility of this, but if we could look at potentially on a state level reversing the contract pharmacy, where the drug companies are able to essentially, and just to explain a little bit without taking too much time, essentially 340B pharmacy or 340B entities, we can have in-house pharmacies and we can have pharmacies out in the community that are contracted. Currently, the drug companies require FQHCs to fill out separate applications for their own programs. So that how that looks is we fill out a program to qualify for AstraZeneca. We fill out a program to fill out an application to qualify for Gilead. And then in terms of the contract pharmacies or the ones out in retail, we can pick one pharmacy location for that particular drug manufacturer's products. So I can pick Albertsons for Gilead, I can pick CVS for GlaxoSmithKline, and so on. So if there's any way to kind of reverse that decision on the state level, that could potentially help us recuperate some of these losses. But just to reiterate, any upper payment limit, $1 decrease in these medications for our reimbursement takes $1 out of our ability to serve the patients most in need.
Thank you, Justin. Appreciate that. I think to be mindful of time, we're about 5 minutes out. I'd like to move on to, I think we've heard from you a lot about kind of, the desired state here, what you would envision, sort of the ideal being, I think, where it's mitigating the impact, the direct impact that you've all described on your entities. I'm curious, thinking more broadly, and you've mentioned a few things, actually, Justin just mentioned a second ago, relative to the contract pharmacies. Are there other recommendations on strategies that you would suggest the board consider in addition to a UPL or separate from a UPL? Really trying to think here, with the board's broader authority, what other policies or strategies might be implemented or advocated for to really address affordability overall. Sort of thinking above and beyond UPL specifically. Yeah, Michelle.
Yeah, I'm going to be a broken record here.
Right.
And really, I again advocate for really focusing more on PBM reform than UPLs, because that is where the money is going.
Are there specific, when you say PBM reform, I mean, that's I totally take the direction you're going. Are there specific reforms? Obviously states have taken, similar but also different strategies to address that. Are there specific things that you think would be have the most positive impact?
Yeah, personally, I think, requiring a minimum dispensing fee. I think most contracts, it's pretty much at zero and has been for a while. And, setting requirements to require them to at least make us whole for our drug costs, right? Plus a minimum dispensing fee, I think will be significant. I think monitoring the rebates that they get and how they dictate formulary coverage based on that needs to be looked at, which has the impact of, people move from health plan to health plan. They have to change an entire drug regimen when they do. The whole industry is opaque, and there's a lack of transparency about the money that they're making, and particularly in the way of vertical integration. So very large healthcare companies in the United States owning PBMs, which own pharmacies. And so that's where the money's going. And I think there needs to be an evaluation at the state and federal level to address that.
I appreciate the specificity there, Michelle. Any other comments on things that you would recommend the board consider more broadly?
And Bobby, I would just remind everyone that I did. It's towards the top of the chat now, but I did put the contact information for both of those bullets into the chat. If you want to copy that down, hopefully you can copy and paste it. And if you aren't able to, or you think of things later, feel free to reach out through those mechanisms.
Thanks, Linda. And just to Linda's point about the chat, as we've been talking, I've been sort of capturing notes and reviewing my notes. I just wanted to let everyone know that we obviously will be pulling all of the content from the chat as well and incorporating that feedback into our report to the board. So didn't want you to think that we were overlooking your comments. We really appreciate them all. So Marty, go ahead.
Just the broken record here, much like Michelle, I think, Bobby, answering your question, what can the board do to support the safety net and FQHCs? And I think a carve out from a UPL is the answer to your question. And that's just being frank with you, because 456,000 Oregonians were able to access their medication in 2022 through an FQHC. And so I think that, and when you talk about how do we work toward drug affordability, that's holding FQHCs harmless and supporting those organizations. FQHCs are on the front lines of drug affordability and access to healthcare. So any impact is a net negative for that.
Thank you, Marty. Much appreciated. Excuse me. Apologies. I know we're right at 1 o'clock, but if there are any other recommendations, any final thoughts in terms of things that folks might not have had a chance to suggest today or talk about today, I want to use this last couple minutes to capture that. Well, if not, again, just to reiterate what Linda had said a minute ago, if you do have additional feedback, please feel free to share that to the email address listed on the slide. We'll certainly make sure that that gets incorporated into our report to the board. And as well, if you have additional comments that you'd like to submit directly to the board now or later as part of their stakeholder engagement process, there's a link to the board website there as well. I think that wraps us up. Just want to thank everybody for your time and attention and participation. This is all good feedback, and we really appreciate hearing from you. So with that, I think I'll call it, unless Shelley, there's anything that you want to add as a closer?
No, I just want to thank everyone for being here and for the very active discussion. As a board, we've put a lot of time and resources and effort into having these meetings. And I just really want to thank everyone today for the feedback that you've provided. It's critical for us to hear as we go through the process. And I haven't heard as much robust discussion in some of the other groups. So again, it just means a lot to me that you're here. I would continue to ask your peers and colleagues to submit the information related to the surveys until that survey deadline. But again, we are listening as a board, but unless someone shares things for us to listen to, it makes things challenging. So again, I just want to very much thank everyone for your active participation in this meeting and the previous meeting that we had.
Okay, well, with that, we'll go ahead and close out and let everyone get back to their day. Thank you so much.
Thank you, everyone, very much.